Hello,
Guys,
sir.
can you please share the PPT?
Sure, sir.
Just check whether this screen visible.
Hi, good evening, Manish.
Good evening, Dr. NLB. Dr. NLB, good evening.
Good evening, Manish. Dr. Jayachandran has joined.
Yeah, I will just we will just check out the PPT and then I will call him.
So can you see my PowerPoint?
No, we can see your document folder.
Can you see now, sir?
No, still we can't see your. I can see your document folder, but the PPT per se is not seen.
Sir, I'll try to rejoin. Maybe I can share after rejoining.
Okay. Guys, can you see the PPT now? You are muted.
No, sir. I have made some editing in this PPT, sir. So I'll try to share my PPT, sir.
Okay, okay. So I will stop share.
Okay, sir.
I finish. Am I audible?
Yes, sir. You're audible. Perfect.
And video is okay.
Yeah.
NLP ready?
I am also audible, no?
Yes, yes,
So-
yes.
Am I
We will-
audible?
Yeah. Maybe you're audible.
Or
So
the
we will start at
video is also
8:30.
okay?
Yeah.
We can
Is it
start
okay?
at
Just 2 minutes.
Yeah, fine.
Guys, did you check your video, sound and everything?
Yeah, we were just doing that, sir.
Okay, please check
There
it.
was some problem, just got corrected now.
Okay, no problem. So 50 joined already. That's good.
Case, you can share the PPT first slide. I mean, just title slide. Then we will start by 8:30. I will just let me just confirm with Dr. Giridhar.
Sir, can you see my presentation, sir?
Not yet. Can see
Previously,
you.
previously it was there, but now we can see the only the folder.
Okay, sir.
Close the, stop the sharing and try again.
Okay, sir.
Yeah, now you can see. Just make it in the PPT mode, presentation mode.
Is it okay now?
Yeah.
Yeah, it's good.
Okay. So can I start?
1 minute.
Just 1 minute.
So-
Yeah, wait.
Okay. So I guess if Girdhar sir or any other senior faculty, I can't see in the list of attendees. They might be joining in between. So good evening, everyone. First of all, let me thank Dr. Jayachandran sir and Dr. Nelby for sparing their time for this teaching session. And today's will be a common or somewhat a common case. One baby with perinatal asphyxia and some complications. And it's generally a common case if it presents. It's a common case for the NNF fellowship exams also. So we just hope it will be a fruitful discussion. And sir, can we start?
Yes.
Yeah.
Very
over
good
to you.
evening, all. And I'm Dr. Jayachandran from Kerala. And nice to see that more than 50 doctors are listening to this. And I have Dr. NOEL from Thrissur Jubilee Medical College with me. We will be both doing the role of examiners. And I request guys to, this being a very long case, we also need a little bit of discussions and doubt clearing, so that will be useful for all the fellows listening or who are preparing for the exam. I request you to present the history briefly, even though there are lots of things in the slides, say the important positive and negatives relevant to this case.
Okay,
And we may stop in between, which is normal in examinations, for some clarifications, doubt clearance, or to ask some questions. So no issue with that. Take it in the right sense. And usually we may expect you to complete the presentation by 30 minutes so that we can have time for adequate discussion. Is that okay?
Yeah, yes, sir. It's okay.
NOEL be okay?
Yeah, it's fine. It's fine. So be relaxed and be confident and present in your way.
Okay.
Okay.
So, good evening. So this is the outline of my case. Baby of XYZ, 38 plus 2 weeks, 2.9 kg female baby, born on 26th April with a history of perinatal asphyxia, HI with complications and sequelae. And we received the baby on day 9, and currently the baby is 1 month old. And the examination was done on at the time of discharge. So coming to the history proper, mother was 25-year-old G3P1L1 with a non-consanguineous marriage and spontaneously conceived. First trimester was uneventful with normal viability and NT scans. And second trimester, she had no gestational diabetes or hypertension. Anomaly scans were normal. She had trichomoniasis treated with metronidazole, but screenings were negative for triplets. And third trimester, no bleeding, no prolonged leaking, growth scans and Dopplers were normal. The birth history, she was admitted at 4 p.m. with pain and leaking and delivered within 2.5 hours. With history of fetal bradycardia and 3 lobes of cord around neck. And the baby came out limp with central cyanosis and bradycardia. Liquor was clear. Heart rate picked up after 30 seconds of positive pressure ventilation, but the baby was gasping and desaturating. So they intubated and shifted the baby to the NICU. Cord gas showed combined metabolic and respiratory acidosis with pH of 6.99 and base deficit of minus 19.4, PCO2 56.5, lactate of 9.7, fitting into the criteria for cooling. So from the NICU, the baby was connected to assisted mode of ventilation.
Hold on a second.
1 minute.
Okay.
What was the ABCA score?
It was not mentioned in that referral letter, so I haven't put it here.
Any concern about fetal bradycardia or abnormal CTG before the delivery?
They mentioned it was like baby had fetal bradycardia, but didn't mention anything in the CTG. So there was some dip, some deceleration. So, but the delivery happened in 2.5 hours. And
Okay.
the Leica was clear, but the baby had cord around the neck and the baby came out limp.
So you said fitting into the criteria of cooling. So what is the NNF stand regarding criteria for cooling? Just in one word. What all
According to the NNF position statement guidelines, the baby should be more than 36 weeks with, and it should be started, the cooling should be started within 6 hours. And baby should have acidosis in the form of pH less than 7 and a base deficit more than 16 with UPGAR less than 5 at 10 minutes or needing PPV for like 10 minutes and a sentinel event like abruption or anything causing an birth asphyxia and moderate to severe encephalopathy should be there.
Fine, fine. You can go ahead.
And the baby was started on total body cooling with Mirac Radial. It was available there. And baby had a hypotension. So they put UVC and bolus were given and started on inotropic support with dobutamine at 10 mics per kg per minute. Baby developed seizure at 4 hours of life, and they loaded with phenobarbital and continued on phenobarbital maintenance, and no further clinical seizures. Repeat gas after 8 hours showed improvement with pH of 7.27, base deficit was minus 10.8, and lactate was 5.1. Echo was done on day 2, showed severe pH and biventricular systolic dysfunction with ejection fraction of 40%. So they added with the intravenous sildenafil. Cooling was given for 72 hours, and the baby was rewarmed over the next 12 hours.
1 minute.
And the
Can you-
respiratory
1 minute. Can you go to the previous slide? This is a
sir.
case of asphyxia baby with
ventricular dysfunction,
ventricular
hypotension.
hypertension. So by this time, hypertension would have corrected. Any other anatropes at this point would you like to add?
Actually, the baby had a systolic dysfunction with low BP. So the better would have like milrinone with some adrenaline.
Yeah.
They have started with the dobutamine and after noticing the pulmonary hypertension added with sildenafil. The better drug would have been milrinone with the adrenaline or noradrenaline.
Fine.
What are the blood tests you can do to evaluate the cardiac effect of asphyxia? If you haven't got an echo facility, what are the blood tests you can do?
It's coming in the next few slides. So we do usually CK, MB or TROPI to evaluate the cardiac injury. So usually the TROPI will peak by 6 hours.
Okay.
So baby was weaned off to HFNC after 40 hours and respiratory support stopped at 72 hours. And once the baby was off respiratory support and the BP was stable, the inotropic support and sildenafil was stopped. Day 1, TROPI was elevated and INR was like 2.31. So they have transfused with the FFP. Liver enzymes was on day 1 was a bit normal and repeat INR become normalized. Baby was empirically started on ampicillin and amikacin. Amikacin 1 dose was given. Ampicillin continued for 48 hours and stopped as the culture and CRP was negative. Sodium was 122 because of the SAADH and fluid were restricted, and calcium was 6 and the baby was started on IV calcium gluconate. Trophic feeds were started once the BP stable and it was gradually increased. So at this point, the baby was HAE stage 2 with MODS features and hyponatremia and hypocalcemia. So the post-cooling, the baby was hypotonic with no cry, no suck or no moro, and had a pooling of secretion. So they added glycopyrrolate and frequent suctioning. Anti-seizure drugs were stopped after a seizure-free period of 48 hours. Repeat blood showed a normalizing sodium and calcium. OGT feeding, the next day the baby was noticed to have some feed intolerance in the form of vomiting and abdominal distension. So they withheld for like 48 hours and restarted once the tummy became better and increased to full feeds by 120 ml per kg by day 9. On day 6, they did the MRI. I'll show you the images. The T2 and flare shows bilateral basal ganglia hyperintensity and on the left frontal periventricular and bilateral peritrigonal hyperintensity and bilateral corona radiata hyperintensity. The diffusion wave images shows the same. Here we can see the basal ganglia echogenicity. It's not pausing. So there is a basal ganglia echogenicity and periventricular, peritrigonal, and corona radiata echogenicity and diffusion restriction.
What about, is there any importance for the posterior limb of internal capsule? Will you specifically look for posterior limb of internal capsule when you see
Uh,
MRI?
Yeah, posterior limb of internal capsule, it will help for prognostication. If PLIC echogenicity, hyperintensity, which is there, it is a very unfavorable outcome. The baby can have a high chance to have a neurodevelopmental injury like developmental delay, CP later on. So one of the MRI finding which is suggesting poor prognosis in HIE.
It's more specific with the motor impairment.
Motor.
Internal capsule is more specific for motor impairment. And basal ganglion thalamic injury predicts higher risk of the neurodevelopmental poor outcome.
Okay.
What's the ideal time of doing MRI?
After the cooling from day 5 to day 7 is ideal time to do the MRI.
Yes.
Yeah.
So after the day 7, there will be pseudo normalization of MRI.
Any other imaging you can do before this?
How
DWI can be done earlier to pick up the diffusion restrictions.
how early?
Even on day 1, we can pick up the diffusion weight images, the diffusion restriction.
Okay, go ahead. Go ahead.
So just one more thing. I know before MRI, what other imaging you can do for this baby?
Ultrasound, cranial UC can be done, which will show findings like cerebral edema or gray-white matter differentiation and hyperechogenicity in the basal ganglia and IVH. And we can do if there is PLIC visibility, there will be 4-column sign. We can assess the perfusion by resistive index.
What is the
Okay.
what
What's
is
the ideal time to do cranial ultrasound?
what is the normal resistive index?
It will be more than 0.7.
0.6
Anything.
to I think 0.6 to 0.8 is the normal.
Okay.
Oh, just go and see it.
Ultrasound was not done in this case, isn't it?
It was not done in this case.
Okay. Okay. Carry on.
So on day 8, the baby had frequent desaturations and baby was put back to high flow nasal cannula. Bloods were done and X-ray was taken to showing elevated CRP with features of an aspiration and bilateral pneumonia. So they started with the IV antibiotics, meropenem and vancomycin, and the baby got shifted to our hospital for further care. At Aster, we started the baby on nasal CPAP with the 30% FiO2. Baby had thick secretions. We did the frequent suctioning. Chest physiotherapy was started. Glycopyrrole 2 was continued. Hemodynamically, the baby was stable. We continued the baby on same antibiotic, did the CSF and ruled out the meningitis. OGT feeds were kept at like 120 ml per kg per day, 2 hourly. And initially, the baby was not tolerating more than that. And gradually, and baby had some vomiting too. So we added the anti-reflux medications. And gradually, we increased the feed from 120 to 150 ml per kg per day over the next 3 to 5 days. Calcium was made oral and vitamin D with DHA was added. And we plan to do physiotherapy and oromotor stimulation once the distress settles.
Can I ask one question?
Yes, sir.
Do you prefer CPAP or HHFNC for term babies?
HHFNC, but in our unit, we usually use the CPAP.
Okay.
Why you prefer HHFNC over CPAP? Which is more dangerous to the lung and which is more effective?
CPAP is because of the PEEP delivery, it is more dangerous to the lung because of the barotrauma. And if there is a poor lung expansion, it would be more better, like a preterm babies. But HHFNC term baby, the HFNC will be less damage to the lungs, and baby will be more comfortable with the HHFNC.
No, basically HHFNC baby will be more comfortable, but it is uncontrolled pressure. So it can be more dangerous. And another practical thing is we will be continuing HHFNC, so more dangerous. Means every day, if it is CPAP, we will try to take off the CPAP. So HHFNC is definitely more dangerous. But some term babies may not tolerate CPAP. They will be more irritable. Okay, go ahead. Good.
The respiratory distress settled in 5 days, and infection markers come down, and culture was negative, so we stopped the antibiotic. Physiotherapy was started, and they trained the nurses and the parents. Oromotor stimulation was also started. Baby had intermittent brief posturing, so we did an EEG and ruled out the seizure. And baby was shifted to the step-down NICU on day 18.
You did EEG for how long the EEG was done?
20 minutes EEG was done.
With 20 minutes EEG, can you say whether it's you rule out seizure or not?
No, sir.
Do you use this AEG near unit?
No, we don't have a CFM monitoring or
Okay.
age.
Okay, then fine. We won't ask that. That's fine.
Okay. So from the step down NICU, baby was kept with the mother attached to the monitor, and mother and grandmother were trained in OGT feeding. Vaccinations were given. OA field, so we plan to repeat after 2 weeks. And parents were trained in the basic NRP. On day 23, the baby got breathing difficulty. The mother had some URI symptoms. So we have to keep nasal cannula oxygen for like 2 days, and then we stopped. Blood and urine analysis were normal.
Okay,
So then the baby became fine, and we stopped that oxygen, and we discharged the baby on 25th.
One question. Is OA enough for this baby?
We were planning to do a repeat OA at 2 weeks and BARA at 3 months.
Is there any screening thing other than OA for this baby? ABR you can
ABR. Okay.
ABR will be better for this baby, no? Well,
Yes, sir.
what's the basic difference between OA and ABR?
This OA will assess only the cochlear, the peripheral, cochlear nerves. It won't be that extensive. The nerve damage should be checked by the ABR.
Yeah, so ABR would have been a better test for this baby. Okay, especially we are expecting neurological injury, no?
Injury.
Yeah. Or BARA later.
BARA later. So short summary from the history is a term AGA female baby with cord around the neck, birth asphyxia with the MODS. MRI showing a deep nucleus involvement pattern, and LOS aspiration pneumonia, and with HIE sequelae like hypotonia, feeding difficulty, and failed OA.
Just hold on a second. What do you think about using the term birth asphyxia instead of perinatal asphyxia, which is more correct?
Perinatal asphyxia would be more appropriate because the baby. Yeah.
Why?
The events start happening during the birth. So even it's not a central event post-delivery.
Causes are antenatal, natal, and postnatal.
Postnatal.
And that's why we're calling perinatal asphyxia.
Perinatal
And if you have
asphyxia.
any legal implication if you're putting birth asphyxia?
Yeah, because it
blaming
distinguishes
the obstetric
between, it's like a pediatric or a obstetric.
Because we are pointing towards obstetric part. So the birth asphyxia time is not recommended now. It should be perinatal. Because there was cord around the neck, there was fetal bradycardia and everything. Is that clear?
Yes.
One more thing to Nelby's point, the ideal method of monitoring this type of babies for seizure is amplitude integrated EEG or CFM. It's just for everybody's information. But that machine is not that difficult to use. I have used it in abroad. It's very expensive and very difficult to build to the parents for a baby with the cooling. That's why many centers are not using it. It got very high prognostic indications also, more than the acute seizure, because there may be EEG seizures. Baby may not be having clinical seizures. Still, baby will be having seizures. That can be picked up with the CFM, and depending upon the CFM graphs, we can have more idea about the prognosis also. So it's very useful, but the problem is it's very expensive. But it's ideal. Okay, ideal to have a CFM. Carry on.
So coming to the examination, The environment on mother side in room air swaddled well, OGT fixed at 20 centimeter. Pulse oximeter was attached and it was showing a normal saturation. Self-correcting desaturation during the examination was present. Vitals, temperature was normal, pulse was 110 per minute. Respiratory rate was 50 per minute, abdominothoracic. Otherwise, it was fine. Head to foot examination, AF was normal. There is overriding of the sutures and cranial ridges. There is no capital subciliary bleed. Eyes, there is spontaneous eye movements on both the eyes, rolling eye movements, no fixation, no dysmorphism. There is pooling of secretions in the oral cavity and an high arched palate because of the OGT kept for longer time. Skin, there is no bed sores or any rashes. Hip was stable, no DDH. Back and spine was normal. Extremities, there is some spontaneous movements in all the limbs. Hand is always kept closed. The anthropometry, I use the Intergrowth 21 chart. And weight is on the lower side, like 2.69. And birth weight was 2.9. So it's showing an extrauterine growth retardation. OFC was normal. Length was normal. We are planning to monitor every week the OFC. Coming to the neurological examination.
So just hold on. We know the nutrition is important in any neonatal case. What action plan you can take to promote the weight gain? Because we may not be able to increase the volume very much. What extra things you can do?
We can
Like it's all
increase
EPM.
the baby is exclusively on breast milk, and we
How
can
many
add like
grams?
now 150 ml per kg per day. The weight loss was happened in the initial 10 days.
Yeah, I know.
And over the last 20 days, the baby is gaining like 30 gram per kg per day.
Okay. Any supplements you are giving?
We're giving multivitamins, vitamin D with DHA. And that's the thing. No
So
other supplements.
Suppose the baby was not gaining weight properly, then what would I be? Then
We
what
can fortify the milk with human milk fortifier.
Okay.
Okay.
And we can, if the baby is able to tolerate, maybe we can go up a little bit on the feeds from 150 to 160. So it depends on how the baby is tolerating. And if the baby has any other symptoms like a breathing difficulty or any anti-reflex, we have to treat the other causes for not gaining the weight. And we can check the sodium and we can add sodium if there is hyponatremia, which will also help with the weight gain.
Usually this sodium loss you are expecting in which type of babies?
Preterm babies, extreme preterm especially because of the sodium loss.
And by which week you expect that thing to be corrected? And when you used to stop sodium supplementation? By around? Suppose the baby was 26 week or 25 week. Sometimes you may start sodium. By which week the baby will start?
By the time the baby about to discharge, like 34 weeks, 32 to 34 weeks, we'll stop the sodium.
Around 32 to 34. 34 weeks. Okay. Go ahead.
Okay, proceed.
So in the higher mental function, state of alertness, the baby was moderately stupor, sleepy with diminished arousal, poor state-to-state variability, and diminished motor activity. An occasional posturing of the upper limb was there. There is no cry. Habituation, no response to glabellar tap, light, or any clapping. The cranial nerves, olfactory, there is no response to the smell of the breast milk. We soaked and kept close to the nose. Optic nerve, blinking in response to the light was there, but bilateral fundus was normal. 3-4-6 bilateral symmetrical rolling eye movement, pupillary response were present, no ptosis or no nystagmus. Rooting and a suck were absent, corneal sensation was present, no facial asymmetry, no startle, blink or any increase in heart rate with clapping. 9, 10, and 11, suck swallow was absent. Pooling of secretion was present. No gag response like while suctioning. And 12th, there is no tongue fasciculations and the tongue was inside when it was examined. Coming to the motor system examination, Bulk appears normal, no asymmetry, and power was more than 2/5, but no movement against the resistance. Tone, posture, the upper limbs and lower limbs were extended with some flexion on stimulation, very occasional spontaneous movements of all four limbs. And then we examined the passive tone and active tone. So in the motor system examination, passive appendicular tone showed arm recoil was absent. Then in the square window, able to completely flex the hand. The angle is only like 15. And in the scarf sign, both the sides, the elbow crosses the midline. So the inference is there is hypotonia in the upper limb. The appendicular tone is hypotonic. Coming to the lower limb, the adductor angle was around 90 degree. The normal is from 40 to 80. This mainly uses to check for the hypertonia. Then the popliteal angle is also increased like 120. Usually in term it is like 90. Then heel to ear. Here we were able to reach the foot close to the ear with the pelvis touching the cradle. And normally in a term baby, it reaches up to only the mid chest. The dorsiflexion angle was normal. Then the truncal passive tone, ventral and dorsal incurvation was increased compared to the normal. An active axial tone was checked with the pull to sit, vertical suspension and ventral suspension. Here on pull to sit, head drops backwards and forwards, and there is no attempt to lift the head. And in vertical suspension, the baby slips through the hands and there is no kicking even when stimulated. And ventral suspension shows the head drops and the back is arched, and legs there is no flexion attempts. And the Galen reflex also was checked along with that, and there is no swinging movement of the hip or the shoulder. So the inference is there is axial and appendicular hypotonia. Coming to the reflex, the knee jerk was a normal brisk, like 2. There is some clonus, but only like 3 movements compared to the usual. There will be like 5 to 10 movements. Then the plantar reflex was bilateral Babinski. The normal response is present. Then the primitive reflex examination, rooting and sucking were absent. There is no grasp reflex. Moro was present, but it was incomplete. ATNR reflex was absent. And placing and stepping reflex were absent too. So Thompson's score at discharge was done, and it was showing like 11. Other systems. Can I continue, sir?
Continue.
So the respiratory system was normal. There is gurgling of sounds due to secretions. Abdominothoracic breathing. Is conducted sounds were present. CVS, the femorals were normal. The BP was normal. Per abdomen, it was soft, non-distended. Umbilicus was normal. There is nothing
Anything
significant.
positive you say about the other systems? Because mainly neurology you have
No,
elicited very in detail. So any positive in other systems?
no, sir.
Okay. So you
Okay.
can summarize because more than 30 minutes you can summarize.
So this is a diagnosis. So HIE stage 3 with MODS and neonatal sepsis resolved. Hypotonia on physiotherapy. With feeding difficulty on tube feeding and ongoing oromotor stimulation with failed OAE, a doubtful cortical blindness and extrauterine growth retardation. Now it has improved.
Okay. Thank you very much, Chris. You have done a very detailed history and very detailed neurological examination, even though it's very good for the other fellows to watch. But in real situation with the real baby on the exam scenario, we may not be able to go through such a detailed exam and baby may not cooperate. I just want to ask you, now you got a baby with a failure to thrive because of obvious reasons and we are on OG2 feeding.
Yes.
So if you're planning in long term, we want the baby to grow. What other methods of feeding you can think for long term other than OG tube?
If the baby, we reassess the baby to see if the baby is able to tolerate orally. If the baby continues to be on orogastric feeding, we'll consider gastrostomy feeding or jejunostomy feeding in a long run.
Okay. And how often you have to follow up such a baby after total body cooling? Any case of perinatal as well as ideal routine follow-up schedule?
Within 3 days, we will follow up the baby because it will be very new for the parents to be with the baby with the OGT feeding secretions. And
Yeah.
the baby needs the OG tubes to be replaced every 7 days or when it is displaced. So
Yeah.
we'll follow up in 3 days, then in a week time, then maybe we space out like bi-weekly.
And then in long term?
The baby needs like reassessment of the neurological status at 3 months, 6 months, 9 months, and 12 months. So we may use any neurological assessment tools in the beginning like Hamilton or Hammersmith. At 9 months, we will go for DDST and for the school screening. And at 1 year, we will go for the Bailey for the complete evaluation.
Other than total body, sorry, there'll be one more question from my side, then you can take over. Other than total body cooling, any other standard therapies is in practice or in guideline in our country? Therapeutic hypothermia plus any other therapy is in the guideline.
Erythropoietin can be tried. Then other adjuvant treatment like allopurinol, xenon, argon. So they are under trial.
Is anything in the guideline yet?
A
standard of care?
No, erythropoietin.
It's not fully in the guideline as far as I know, but that seems to be a promising one.
How erythropoietin acts? How erythropoietin helps?
Erythropoietin, there is some receptors in the brain. When we give the erythropoietin, it helps to, it binds with that receptors and it prevents the apoptosis of the neurons. So it reduces the delayed neuronal damage.
You said for seizure you have given phenobarbital. What is the problem for phenobarbital? What is the issue for
prolonged use can lead to neuronal apoptosis and behavioral problems in the later on.
Neuronal apoptosis is a known complication.
It's a known complication.
Go ahead.
Just one more thing. Have you heard about biomarkers for HIA?
Yes, sir.
Did you heard about such a term?
Yes, sir. So we usually use like biomarkers, troponin I, CKBB. Other rarely used ones are neuronal specific enolase, S100 beta,
Excellent. Thank you. Just everybody needs to
interleukin
be aware
6.
there are some biomarkers for HIE. Okay. Anything else in your presentation?
So this is our follow-up plan. So we'll
Yeah.
discharge the baby with feeding tube and change the feeding tube every 3 to 7 days or when it is displaced. And we train the parents for using the suction apparatus and explain the red flag signs like breathing difficulty, persistent desaturation, aspirations. They have the saturation probe. First follow-up in 3 days and then weekly. And we registered them for the neurodevelopmental clinic. And vaccinations were given option, and we'll consider giving optional vaccinations and cocoon vaccinations if they are willing. This is a checklist at the time of discharge. So we'll continue with the physiotherapy, oromotor stimulations. We'll consider BERA and visual assessment, and we train them for the resuscitation. That's it. Thank you.
So this baby, if it was, if there was not a clear history of this cord around the neck or this thing, just and the baby was not depressed, and if you are getting similar MRI finding, what all things will be the differential diagnosis? This basic involvement.
We'll consider any brain malformations or any inborn errors of metabolism. It's like glutaric aciduria type 1.
Yeah, that's what I glutaric acid. Yeah, fine. Very good. Very good. Yeah.
Thank you, sir.
I think it is a very good presentation. Excellent. And you answered almost all the questions. It's good that you read about the topic very well before presenting. I hope the other fellows have something to learn from it. And congratulate Dr. Binish for training in a very good manner. And the slides was very good. Especially if the cases were not fully looked after by you. So there may be some missing in the history or because you got the baby only after 9 days or something like that. But overall, it was a very good presentation to the point, and especially the detailed neurological examination with videos, which was very, I'm sure it will be very helpful to the other fellows watching the exam, this Zoom meeting. Binish, do you want to add anything?
From my side, I would say it was an excellent presentation.
Thank you, sir.
Especially, I congratulate Binish and the Dr. Kais for very good presentation, meticulously presented. Yeah, this is more than enough. Good, good.
Thank you, sir.
Binish,
Yeah, I guess if there is any questions or comments from the any of the audience, we can take it 1 or 2 questions in the 1-2 minute.
Okay, that'll be good.
Otherwise, and let me again thank Jendran sir and LB for sparing the time. And I'm sure it should have been for all the attendees it would have been it should have been a good experience, and we will just wait for 1-2 minutes, and then if there are no questions, we'll log off.
Dr. Binesh Giridhar here. I had just a brief comment. Nothing about that case and all. Since there are a lot of fellows who are attending this program, I think this program has been designed to actually improve your knowledge and make it more interactive, so that you come up with your what you want to know and post it at least in the chat box. Because we have been seeing the last 3-4 programs that the interaction from the participating audience has been very less. Okay, so I think it is better that I think some feedback comes from the audience. At least we have this the recordings will be later uploaded to the NNF website and also the DJ NNF platform. At least some questions you can, if you have, you can post it in the DJ NNF platforms also. That's a discussion group for NOEL on this. But so far, no questions have come from this. So at least for the participating audience, the fellows, please post some questions to the DGNF platform so that this can be seen and the discussion can be started. Of course, a good presentation. I think if any questions are there, you can take it up, Binesh. Yeah, I
Yes.
think the question has been asked for the recorded version. Recorded version will be available in the first week of June. It will be available on the NNF website, the official YouTube channel of NNF, and also on the DGNF platform. It will be there. So I think you can access both of these areas. So but the only thing is there is one more option for having an online discussion related to this videos which you are posting in their DGNF group also. So you can have an online discussion there. Any posting can be posted there also. I mean, it can be done at a later point of time and it will be answered by the concerned faculty. So there's a question on how long should the EEG or the EEG be done for and what day the post dictal. For this,
You know that
presenter can take it up or
First, we'll,
yeah, guys, do you want to answer it? How
Yeah.
long the EEG need to be done?
first we will give the option to the presenter. Let him answer.
The amplitude integrated EEG, we usually start at the time of cooling and will continue 8 hours post rewarming, and we will stop it.
The next question is, what are the modifiable factors that determine the outcome of a baby with perinatal asphyxia?
It starts from the
Yeah, you can continue.
it starts from the antenatal period, the better antenatal care, and the regular follow-ups. And during the delivery, it should be the delivery based on the risk factors. It should be attended by the a team if there is a high risk factors. Post delivery, the cooling is a one therapy that will help to in moderate to severe encephalopathy. It will reduce the neurodevelopmental impairment if the therapeutic cooling is given in a proper way for like 72 hours followed by rewarming in 12 hours. And the seizure management, if there is no, if it's possible, we can monitor the EEG. And if there is any seizure, if it is properly managed, it will help in along with the cooling, the development of further neurodevelopmental damage.
Next question also you can try to answer.
Apart from that, I guess, especially in a case of cooling, the temperature fluctuation is very important, especially if you are not using a servo-controlled machine. And the identification of seizure is important. The metabolic parameters like the hyponatremia, calcium, sodium, hypoglycemia, especially hypoglycemia is very important. So I guess the next question is, phenobarbital is still being used as a first-line anti-epileptic drug, though we know that there is a risk of neuroapoptosis is there. So is it the question? I guess the question is it still the first-line drug for asphyxia, or is there any guideline to use levetiracetam as a first-line drug?
Phenobarbital is again back to the first-line drug for HAE seizure because it works better when there is cerebral edema, and short-term use of phenobarbital will not lead to any later on complications. So the recommendation is if there is no seizure for 2 days, 2 to 5 days, the anti-epileptic can be stopped. And before stopping, it's better to have an EEG to make sure that there is no non-clinical seizures.
What is the reason you are saying if there is no seizure for 3 to 5 days, you can stop anticonvulsant? What is the reason?
There is evidence like prolonged use of the anti-seizure medicines and stopping the medicines showed there is no significant difference in the long-term outcome.
And also, once it is seizure-free, there is less chance of recurrence.
Recurrence.
But all it recurs by 1 year. because of the neuro. So there is no point in prolonging the anticonvulsant.
And
Okay, sir.
case I must correct you because even the short time use of phenobarbital or even benzodiazepines, even few doses or 1-2 doses has proven to be causing neural apoptosis in experimental models. So even the short time use has some evidence to show that it is neuroapoptotic. But as of now, still all the major recommendations from the ILCOR or all the bodies is to use phenobarbital as the first line. So by guideline, phenobarbital is still called as first line. But due to various reasons, because of the long decades of usage, the efficacy data, etc., etc. But it may change in the future.
Dr. Benish, most
Yeah.
important reason would be because this phenobarbital have better efficacy compared to any other drug.
Yeah, some of the studies, especially NOEL D, etc., some of the studies has shown that phenobarbital may be effective, but again, there are controversial data against that also. Those who favor Layfield does have its own their own studies to show that it is probably good efficacious, but it's slightly gray area, I guess, as of now. But as of now, as to the best of my knowledge, all the major organizations is still the first line drug to use, not only in asphyxia, but in genital seizure is phenobarbital.
I don't think any other questions came in the chat box.
As of now, no, sir.
Okay, we can possibly conclude.
Girdhar sir, can we conclude the session?
Yeah, please. I'll just make a small comment regarding that modifiable risk factors which determine the outcome of a baby with perinatal asphyxia. I think as practitioners, we need to know about the enough position statement on therapeutic hypothermia for moderate to severe encephalopathy after HI. And this statement was released after we had a meta-analysis on various factors that determine the outcome. So in that, they have particularly seen about the cot pH at admission, the place of delivery, whether it is going to be intramural or extramural, and also the admission temperatures. So right now, if the baby is getting transferred from extramural unit to your unit, and for therapeutic hypothermia, but it lands up with a low admission temperature, then the outcomes are not likely to be good. So the era of passive cooling is gone, like cooling during transport is gone in India. So I think we no longer advise that. What we advise them is only babies to arrive at your center with normothermia. So people who are doing retrievals in babies who have had a significant perinatal hypoxia, at least maintain a normal temperature during transit so that the baby reaches with a normal temperature to your unit. That is one modifiable risk factor. The second is going to be your cot. Of course, intramural babies have better outcomes. People know that. And already you had mentioned about the glycemic status. Hyperglycemia with encephalopathy is a very bad prognostic marker. I, I think people have to somehow ensure that the babies have a normal sugar status. Basically, their sugar records have to be normal, and hyperglycemia has to be avoided. And also you were mentioning about the tight control of temperature. Rapid fluctuations in temperature are deemed to have a poor outcome. And also babies who have not maintaining saturation, undergoing cooling with your respiratory care, like you're having severe pulmonary hypertension, those are the babies which tend to have a even worse outcome. Sometimes we know that cooling could precipitate your pulmonary hypertension, and a lot of units also don't actually cool if the FRT requirement is very high and the babies have severe pulmonary hypertension. So those are the risk factors people have to talk about when they talk about the modifiable risk factors in a baby with perinatal hypoxia. I think, as you said, the phenobarbital is still the first-line anti-epileptic drug. Although I think it is from the NEOL True trial. Although I think newer trials are on the anvil, so we'll have a answer later. At this point of times, as per recommendation by ILAE also, I think phenobarbital is the first-line anticonvulsant therapy for any neonatal seizures, including those with HI. Yeah, I'm done with my comments.
One more point to add. to have better temperature control, servo control missions are better compared to the phase changing materials or other cooling methods, which is a little bit
Yeah,
expensive.
definitely.
Regarding this admission temperature, still now a lot of people are having the false belief that anyway we are going to cool, so let us give this false
Exactly.
passive cooling. Actually, this admission temperature gives two indicators. One is it indirectly says the severity of asphyxia is severe. Second thing is our supportive care is not very great. These are the reason. These are some of the reasons that clearly showed that this admission temperature, if it is less, have poor prognosis. So that, as Dr. Giridhar was saying, there is no role of passive cooling. It should be controlled cooling.
A very good resuscitation as per NRP is a vital role in saving this type of babies. Because unfortunately, the baby was born with asphyxia, but what we done in the first golden minute or first golden hour matters a lot. Whether we have done a very good resuscitation, including all these temperature factors, will have significant influence, acute and in long-term outcome.
Just one more question, probably that's the last question. So how to manage the breakthrough seizure if we stop the phenobarbital early?
We have to restart with the seizure medications, and if it depends on how the seizure is, like if the seizure is lasting for more than 3 minutes, or if there is like frequent seizures, like 3 seizures in if like a short seizure, 3 seizures in 1 hour or more than 2 in half an hour, then we have to consider adding the seizure medicines and do an EEG, and we have to decide based on the EEG that seizure medicine should be continued how long.
Just to add to that, so of course, so the point is that we need not treat every small moments. It should be a significant seizure. There is no point in aggressively treating every small twitches and the suspected seizures. Again, no advantage in continuing AEDs for a long time if the baby is seizure free. And third is that in most of the asphyxias, generally the seizure do settle by 5 to 7 days. And these very few percentage of these babies do have breakthrough seizure and the actual need for long-term AEDs also. So for any breakthrough seizure, you just treat it as a newborn neonatal seizure, like the same protocol.
I agree with Binish. Even after doing more than 100 cooling, very, very rarely we send them home on anti-epileptic medication. Very rarely they are on continuous medication.
I think questions are,
I guess
because it's about 1 hour since we started, so possibly we'll wind up.
yeah. Thank
okay,
you.
so then if there is nothing from your side, sir, may I close the session and.
Thank you, Giridhar, for coordinating all these
sir.
things. You're doing a great job.
Thank you, Dr.
Yeah.
Thank you, Vinesh.
Yeah.
And thank you, Dr. Jayachandran.
Thank you.
Yeah.
Thank you, everyone.
Thank you, Jayachandran sir. Thank you, Melvi, Binesh. I think you please
Thank you
join us
all.
for further sessions also. The link to this NOEL sessions will all be the same. The login link will be the same. So I would
Okay.
request that the older faculty also please join during subsequent sessions, which will be happening on every Thursday, sir. I think your comments during the session also will be welcome.
Sure. Okay.
Thank you.
Bye,
Thank you, sir.
Giridhar.
Thank you, everyone.
Thank
Have a
you,
good
Bye,
night.
Binish.
Bye-bye.
Good night. Thank you.
Good night, sir.
Good night. Good night.